My name is Dr. Paul Key. I practice pain management here in the Valley, Fresno, California, and I am the owner and medical director of Advanced Pain Solutions here in Fresno, as well as the CEO and owner of Key Advanced Surgical Center. And we actually have done great strides in terms of minimizing the risk of surgery because of the time management with the minimally invasive spine surgery, such as OrthoFundamentals. We've dropped OrthoFundamentals procedure down to less than 30 minutes. For illustration today, I actually have 3 SI joint fusion cases. One is planned for a 70-year-old female who has had multifactorial pain syndrome, including lumbar spinal stenosis, as well as facet tropism and SI joint dysfunction. The patient has had a interspinous process distraction device at L4, L5 by another physician in 2020, and that seemed to resolve her ridiculous symptoms. She also had an SI dysfunction, and as a result, we had undergone 2 diagnostic injections, and she responded really well. And then subsequently, we did a left SI joint fusion, and now, over 3 months later, she couldn't wait to get the second one. So I tend to go coaxial. She is arched quite a bit. Right there, I hit the bone already, okay? Again, just a little bit lateral to the iliac crest. And that's desired right there. And it doesn't take much to move from the iliac crest and drop down. It takes like a couple of millimeters or less. The starting point is a little bit caudal. If you look at here, here is called the iliopectineal line. That line cannot be breached. As I mentioned earlier, that is the most rostral portion of the ala. And here's the lateral view showing the anterior portion of the ala. Okay? Now you cannot see this because you have to use the promontory or the anterior portion of the sacrum or sacral body, but the silhouette there gives you a false silhouette. Really, it's sloped. The ala slopes down, so it should be anterior to that. But this one, we will best see it in the sacral view or the inlet, modified inlet view, contralateral. That will be a bit better, okay? But right now, we want to focus on the iliopectineal line. So knowing this, I will numb it up a little bit more rostral so that I can get that trajectory correct. The cut is about a little over 1 centimeter. And here's a Jamshidi picture. And that's kind of like an ideal position for me right now. So I will tap it in a little bit. Okay, picture. Good. Let's go to lateral view, make sure the trajectory is correct. As you can see, the trajectory is ideal, okay? So I'm just gonna go, it's almost symmetric to the other side. Picture. I'm okay, like this is a good trajectory here. Okay, let's get the inlet view. Inlet view is when the anterior portion is, in line or silhouette over the posterior portion or most caudal portion. And then you're looking at here's more the posterior, here's the anterior of the sacrum, okay? But let's do the modified, right? So that we can look at the SI joint view. And here the SI, if you look at the SI joint here is overlapping each other, okay? So that's ideal. As long as you're not breaching all the way over here, then you're pretty safe. And my trajectory there is good because it's already pointing towards, picture, the ala. Picture. As it went through, you can feel the difference in terms of pressure and texture. See? Picture. And that's ideal. That's right there. That's enough. Okay? You're leaving like a little over 1 centimeter. It passed through the SI joint and is right in, I would say, like 40% into the ala. And here's part of the vertebral body of S1. So this is ideal right here. As you can see, because of the design of this instrument, they create much greater surface area. So as you go, obviously, no matter how safe it is, you still want to be careful as you go, and then you sense that there is an endpoint. I still used a little tapping to kind of like set it in place, otherwise it'll come out, okay? It's just kind of planched out and it's protective. The bone density is quite well. Oftentimes the other patients who are severely osteoporotic or osteopenic, they actually do not exhibit that kind of thudding sensation. And this one, I'll just thrust it all the way to the bone. And then here, you get the depth gauge, okay? Here it says 45, okay? So 45, you got plenty of room. I would drill down to 40. Here's a working channel or a trocar that kind of sets it in place. And again, I kind of grind it all the way to the bone to ensure that it is docking correctly, okay? And now it's in place, then we're good. So you can see, we set it up at 40. The depth gauge was at 45. So to ensure safety, I would dock it at 40. You know, any drilling, just like if you're used to drilling wood or plastic, whatever it is, you want to have some leeway for some purchase by the actual screw. You want to hold it stationary so you don't have any wobble effect. When you have a wobble effect, then the drilling, the hole is larger than what is needed, right? So you want to minimize the wobble effect. Picture? Okay, there you go. It's almost flush with the guide wire, okay? That's it, we got it to the depth of 40 and it will be flush with the working channel right here. You can't depend on this solely, so you gotta look at the x-ray, look at the working channel, and also ensure that the gauge is still at 40. And then you will have to reverse this ratchet. So once this is engaged, pick, then I'm gonna take out the K-wire. So now it's engaged already, and I maintain the actual working channel, so I'm able to salvage it. I don't want it to breach the cortical bone. Picture? Now we're heading. Picture? Picture? Okay, let's confirm that the screw is flush. We're gonna get a teardrop view to make sure that the screw is flush with the iliac crest on the lateral aspect. As you can see, here it's perfectly flush. And we want that flushness because otherwise, sometimes when the patient walks, then the gluteus maximus, part of that fiber, can flick and the patient will experience pain. So you want that flushness. Pick. Make it a little bit more lateral, or move the tip more medial. Picture. 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 Okay, I just breached the SI joint. I felt the give. So I'm just gonna stop right there, local. Picture. Sometimes I just push it like this. The friction alone controls it in place where you can just draw this without it coming out. Otherwise it'll follow through and the actual guiding wire will come out also. Again, you want to thrust it all the way to the bone. Yeah, let's go to 35. That's your call. Normally you want to limit by 5, no, a delta of 5. If the measurement is 50, you want to drop it down to 45. It's somewhat corrugated because that's their trademark. And I like the way they make this pitch so it really grabs onto the bone. It's self-tapping, as you see in the front. It's more like a boring, you know, those tunneler that you've seen on TV. And kind of like that, it bores through hard bone. This one goes in a lot easier. Picture. I want to make sure as I'm doing this that the alignment is okay, because if it's not, it creates a lot of friction and it's flush. When there's a marker here, when it's completely flush, that is consistent with the measurement, the initial measurement. Picture? Okay, and that's enough right there. If you take a look at here, see we're still, if you look at it's flush, it's still behind the modified inlet view, and the other one is still quite behind, but it passed the SI joint, so that's sufficient. So it's both flush on both sides, and it's not breaching the anterior cortex. So there, the teardrop shows that it is across the SI joint. Based on my experience with OrthoFundamentals so far, I enjoy using the product because it has made my practice much more efficient, and also the outcome has been phenomenal.